Oh, hi. Wow. It didn't tell me that I was actually live here. Good afternoon. Gosh, we're having a little trouble getting, let's see if we can do this here, trying to get the CNY feed to work. Oh, there it goes, I think. Okay. Well, that was really a peculiar introduction. Good afternoon, CNY Nation, live from Colorado Springs. I'm Dr. Randy Fink, the clinical director of IVF services here at CNY Fertility, Colorado, and medical director at the Miami Center of Excellence in sunny South Florida. And like we do every Tuesday afternoon at 4 o'clock Mountain Time, 6 o'clock on the East Coast. It's Fertility with Fink and Friends. I am Fink. You are friends, and it's so nice to see everybody to be here with me today. A little strange introduction there as we started. Hi to, is that really Carmen Segue? The Carmen Segue that I know? Unbelievable, who happens to be on LinkedIn. Good to see everybody. Hello to Mrs. Vincent, to Grace Tongue, and Allie is here. Allie, you are the first one to join on the Randy Fink MD Instagram. So you get a gold star right there. Thank you very much for being here. And hi to Amanda. And it looks like Ilu Minati. Hi to lovely Zaneta in Miami. And to Sam, and hi to Paige, who had a very big day today. A special greetings this afternoon to our global nurse, Enna, who appears to be with us on the show. Good to see everyone. Elu says, me and Desiree looking forward to our transfer, which hopefully means it is coming up very soon. Hello to the Salustio clan, and a special greeting to Angela for being here up in sunny, warm Minnesota with all those people with great hearts, right? Great hearts. They have great hearts when you are taking care of them. And over here on the CNY side, let's see who's here. Tiffany P was our first to join. We've got Cheryl Love, uh, XO the Blueprint. It looks like Liver Tyler. Ski and Sand 802. Oh, I like that name. That sounds pretty good. All kinds of nice folks here. Hello to April V. Vaughn Does joined. Good to see everybody here. The Fertility Conversation. That's a good name too. And we are a good fertility conversation. So how's your week been, and how was the weekend? And, we got a little snow here in Colorado. And of course, as per routine, it melted really quickly. So there wasn't a whole lot to talk about there. It's been chilly. It's kind of getting darker earlier. And so, it's easy to get up in the morning when it's dark and go into work, and then be inside all day, and then to leave at the end of the day, and it's dark. And this is the time of year that people start to get a little melancholy, and all the things that are happening in life sometimes make it even easier. Well, we do care about your mental health, and this is one way that we can address that by being right here with you. A forum for you to be able to talk to your friends, to people who go through the same kinds of things that you're going through, as far as getting pregnant and staying pregnant, and those trials, because it's a difficult and rocky road, as we all know. And so I think it's very helpful when we know that there are others who go through it as well, and who have been through it, and who can share their stories and share all the love we have here. I do want to send out a very special greeting to a very, very special woman whom I have spoken to before on the broadcast here, and that is none other than Mrs. Emily Fink. That is right. My mother, Bama Gal, just joined, and I want to say a very, very special birthday greeting to my mom, who turned 85 beautiful years young just yesterday. And we wish we could have been with you there in South Alabama, but we know that you are with me every single day and every single minute. And you and Dad are very, very special. And I thank you for all that you have done. And thanks for watching my broadcast. She always says, "Oh, you're doing that fertilizer with Fink and Friends." And Mom, it's not fertilizer, it's fertility. Fertility. It's about having babies, getting pregnant, and that sort of thing. She says, "Yeah, yeah, the fertilizer." No, no, it's not. It's something different there. Look, oh no, and everybody's saying happy birthday, Mama Fink. Thank you. I hope that she has the ability to be able to see some of the little comments there. So very sweet. I did get a question that I want to answer here before we get to your questions, and that was, anybody who knows me and who comes in here to Colorado often asks to see what kind of socks I'm wearing, and they say, why do you and Brandis there always wear some kind of fancy socks or colorful socks, and what's up with the socks? And well, I can speak to myself that as a guy, I change my glasses a lot. I have some different frames that I'll put on, to try to dress things up. But most of the time, when it comes to being at work, I am wearing my what amounts to PJs at work, and I don't have fancy jewelry to wear. I don't have big gold chains, and I don't have a gold tooth. And so they're like, why do you guys wear these socks? Because and from a guy's perspective, since I don't have a bunch of rings and bracelets and this sort of thing, it's the only way a guy can really dress things up is to wear fun socks. So I like to wear fun socks. And I suppose it's really probably the same for women. Women can, you can have lots of different earrings and different, accoutrements that may be more socially acceptable than it is for men. But it's probably close to the same thing. It's just fun to wear fun socks and you kind of try to dress things up. Yes, I said gold tooth. I did. Okay, so let's see if we can get to some questions here. I see there are a few. You know what? We're going to start over here on the Facebook side. This comes from Tamara, who is generally here with us on Tuesdays. It's nice to see you, my friend. Thank you so much for being here. I'm on Immune Protocol 3, and I am 5 weeks pregnant. Holy cow! I didn't realize. That's fantastic. Post-transfer with CNY. I have had to change when I take my injections from being distributed throughout the day to 4 injections in the early morning and one later in the day due to work concerns. Will this affect the embryo development and pregnancy? The answer is likely no. So as far as injection and timing, in general, you kind of want to be able to keep it consistent. But if you've changed it, and you're able to run it on consistently, then you should be in really great shape. Hey, congratulations to you. That's so exciting. But 5 weeks, I don't know which is worse. That time period between 5 weeks and when you do your first ultrasound, where you see the pregnancy inside with the heartbeat, whether that's harder. And by the way, once we look and we see a heartbeat, we know that 95% of those pregnancies will continue. So, oh my gosh, that is the best news. The best hurdle to jump over is to be able to see that heartbeat. Is that harder, or is it harder to wait between the time of transfer and the time of the pregnancy test? Those are both really difficult times, but you know what? You made the first obstacle. Can't wait to see the good news, Tamara, with your ultrasound result. All right, we're going to switch over here now to the CNY Instagram side. I'm sorry. Yeah, that is the Instagram side, and see what we have here. I saw there's a couple of questions. This comes from Mully216. Just had a loss at 10 weeks. I am so sorry to hear that. Did immune protocol number 4 with IVIG and Humira. Did HCG wash and boosters. So what would be next? It's the 5th transfer since my son with donor eggs. So the immune protocol level 4 is kind of the biggest gun that we have for doing things to try to treat autoimmune issues and inflammatory issues that can prevent people from implanting or from being pregnant. Now, the fact that you had a loss at 10 weeks suggests that there was likely something else going on. And the fact that you are on immune protocol 4 suggests to me that you have a history of something like this happening in the past because we don't generally start with that stuff. IVIG, IV intravenous immune globulin, and Humira, which you may have seen advertised on TV. It has like 40 different indications. It's a type of a biologic drug. This tells me that there's something going on in your body there, and I think really, Molly, the question is, well, what is that? Is this an immune situation? Because when I see losses that keep happening around that 10-week mark, 8 to 11 weeks, I kind of wonder about things with blood clotting. Now, if you were on that protocol, you were already on Lovenox. Lovenox is the blood thinner, and that's really what we use that's what we use to treat these blood clotting type problems. So my guess is you were on that, but I certainly think, this bears probably a much deeper conversation. Immune level 4 is kind of the biggest gun that we have. And I will particularly use the IVIG in folks who have had otherwise unexplained miscarriages in the first trimester, thinking that, well, if we can't figure out what's causing it, then there must be something about the body that's trying to prevent that pregnancy from growing. Sometimes we don't always have the answer as to what that is, but once we're on immune protocol 4, we're trying to tick off all those boxes to cover all those bases about what some of those things might be. So, Molly, our thoughts go out to you here, and certainly keep our fingers crossed for the future. But please do follow up with us, because that's definitely worth taking a close look at. Hi to Looking Glass and Naomi Perry, Lindsay Bella, Christy Bowerman. I had my transfer. This comes from Lynn's. I had my transfer on Saturday. My estrogen was 82. So I took 2 days off estrase. Well, so the estrogen level, I want you to understand, at the time of transfer, and really afterwards, isn't so critical. The progesterone level is a lot more important. What's more important around the time of transfer was, what was that lining? What did the lining look like really at the time of progesterone start? Because then it starts to compact. But we want that uterine lining to be about 7 millimeters minimum. The level of the estrogen becomes less important. We do test it. And why do we test it if it's not important? Well, that's a good question, and it is controversial. But I think the reason, and I've said this before, is that if we didn't test it, then people would be calling on the phone, well, I want mine tested because I saw on social media, I saw on the internet that you're supposed to have it tested, or somebody told me that they had theirs tested. And so therefore I want to know what mine is. And so we really got so many phone calls like that, at that point, we just said, we're just gonna test them for people. But taking 2 days off makes sense, and I will keep my fingers crossed for you, my friend. Let's see, from Liver Tyler, what happens after a consult if your periods are very irregular, like every 3 months or so? Do you have to wait for your cycle to come? No, you do not. So first thing that happens after the consult is that we're going to order some testing for you, which is going to be some different medications. It's going to be, different medication, different hormone levels, and usually some imaging tests, sometimes an HSG, and certainly a saline sonogram, so that we can evaluate the uterine cavity. But once that testing has been done, usually what we tell people is, okay, so within a week to 2 weeks, you're going to get a phone call from our global team, and the global team is going to orient you on the process and the logistics, and set up the monitoring for you, so that everything is kind of all ready to go. And then we just want to hear from you when you get your period. Okay, so you don't get a period. You don't get a period but once every 3 months. Do you have to wait 3 months? No. Usually what we'll say is, after that, typically if your period comes, or 30 days, but you don't even necessarily have to wait that long, because what's happening in that situation? Well, when you're not getting your period, well, why do you get a normal period? It's because your ovary releases an egg. You develop an egg in the ovary that grows up and gets mature and then gets released. And once it gets released, it hangs out. Oh, I hit the microphone. Sorry about that. It hangs out and waits for a sperm to come along and fertilize it. If a sperm comes and fertilizes your egg, then woo, you're pregnant. The brain says ding, 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 do all those things. And it does actually make that noise, ding, 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 and probably that face as well. Do all those things that you do when you get pregnant. And if it doesn't, it says, crap. And it does actually say crap. Not pregnant. Okay, fine. Well, shut off the hormones, clean everything out, and we're going to start again fresh next month. And that is the signal to have your nice normal period. So if you don't release the egg, then you don't get the signal. And if you don't get the signal, then you don't have a period. So what happens there is that, well, what happens in your natural cycle before you release the egg? You're just kind of in the first half of your cycle. In fact, your body may even think you're still at the beginning of your cycle, because you're not really forming the egg that's going to go on to get released. So if you're waiting a few months to get your period, in most cases, during much of that time, your body still thinks it's sitting around at the beginning of your cycle, not doing anything. So what do we do there is that we check your baseline labs. We'll do an ultrasound and see that your ovaries don't have a follicle, that you haven't formed something that's growing, and check your blood tests to show that your hormone levels are at the ground level. And then that's how you begin. We usually like to start things at the beginning of a cycle. Sometimes we can start things later in the cycle. That's called a luteal phase start. But just so you know, your body's hanging out there, and it's not doing too much. And so we can check in on that and then get things going from there. So that was a good question. CM Russo tells me, I must also throw out a special hello to nurse extraordinaire Jody Hoffman. Jody is one of our Global Connect nurses who used to be the nurse manager here in the Colorado office. So Anna was on one side, who's now with Global Travel. Jody is with Global Connect. Jody just came back from Korea and had a nice trip there. And we got to see some fun things on her Instagram. She ate some crazy Korean food like Texas Roadhouse and probably even McDonald's. So way to go, Jody. Way to show them how to live. Okay, let's see. CM Russo says, I had a retrieval a few weeks ago, retrieved 13 eggs. Upon retrieval, all 13 eggs were immature. 10 matured overnight in the lab, and 5 made it to blast. Is there a higher likelihood of aneuploid when eggs matured in the lab? Well, that is, it's a great story. I'm so happy that you got 5 blasts. So what that tells me is that they are probably on some level, at least, something about them is normal. Otherwise, they wouldn't have grown to that blastocyst stage. They would have just stopped growing. So there is some evidence to show that late fertilizing eggs may have a higher risk of aneuploidy. However, we don't really know if the situation was that they didn't fertilize or that they well, actually, you're saying I'm sorry, it's a maturation thing. They matured in the lab. Sometimes what we'll do is we'll go to fertilize an egg, and then we'll look at it on day 1 to see if it's fertilized, and it doesn't look like it fertilized because there's something about it that the embryologist is seeing, that they miss that fertilization window. And so in that case, it actually did fertilize, but it we don't see that until a little bit later on. In that case, it's expected to be a normal embryo. What you're talking about is where the egg itself, I'm sorry, I got a little sidetracked there. The egg itself is not mature, and it matures in the lab. Nope, that should really be fine. That's called in vitro maturation, and that happens, and that should be a-okay. So good story there. Congratulations on that. 5 blasts. So happy for you there. Crystal Kathleen is asking, is there such a thing as an over mature egg? Well, yes and no. There isn't an egg necessarily that we will look at under the microscope and say, ooh, that one's over mature, because you can look at an egg and see if it's under mature. If it's an immature egg, that's something that we'll know about. But an over mature egg, it's not that you look at it and say, oh no, that's gone beyond. Um, what can happen is that as a follicle gets bigger and bigger and bigger, eventually you may release it. You may ovulate that egg, and then we miss it at the time of egg retrieval, or it can start to degenerate. It can kind of just sort of start to fall apart. So it's possible in that regard, but there is not part of the grading situation where you look at an egg. You can grade an egg that looks under or immature, but you don't grade an egg that looks over mature. All right, what else we got here? Joanna May has a sad story here. Unfortunately, no heartbeat at 7 weeks, 5 days post fresh transfer. None of my other embryos made it to blast, so none were tested. Would you recommend having the miscarriage tissue tested to determine if it was chromosomal in case we move forward with another egg retrieval or IVF? Well, so Joanna, not necessarily, because in all probability, if you had a miscarriage, and we are so sorry to hear this, because it's a terrible thing to happen after you've been through this roller coaster of a process of IVF. The miscarriage is just it's cruel, as I always say. So sorry to hear that. But if you're going to have a D&C, odds are that miscarriage occurred because of a chromosomal issue. Most of these chromosomal issues are things that develop just from the moment sperm comes together with egg. It does not mean that there's going to be something hereditary or genetic that's passed along from parent to offspring, that you're going to have a bunch of offspring with that same chromosomal issue. Because, as we mature, the DNA that's in our eggs becomes less stable. So we are more likely to produce an egg that has a chromosomal abnormality. And in fact, all sperm is not normal. It's a little package of DNA with a motor on it. And sometimes that DNA becomes abnormal, or it can become what we call fragmented. If we tested every egg, if we were able to do that, which unfortunately we're not, but if we could test every egg, we would find that, well, depending on your age, there's going to be some component of those. And frankly, even if you're 18 years old, there's going to be some component of your eggs that are normal, but there's going to be some component that are abnormal. And of course, as we mature, as we age, the larger number of those eggs are going to be abnormal, such that at 38, 39, probably 50% of the embryos are going to be abnormal that we create based upon the eggs. So that doesn't mean that there's something wrong with us, that we're broken, or that we have some genetic issue that's passing on to the embryo. So it may be satisfying to find out, yes, this was a chromosomal abnormality that caused your miscarriage, but it is not likely to be a useful finding. In other words, something that would prevent other pregnancies from growing. Because God willing, in the other embryos you have something that's normal. Unfortunately, you can't tell from looking at them. And, even again, when you have a PGT tested embryo, sometimes we find that even though it says it's normal, those embryos turn out to be not normal, or sometimes they can still miscarry. So it's a challenging situation. But no, I don't necessarily, on a first miscarriage, I don't necessarily recommend genetic testing of the products of conception, because it may just create more questions than answers. It may not actually be very useful information for you. Let's see. And so sorry, Joanna, that you have to go through this. Coming from Kristen, thoughts on Provera? Is it a replacement for Cetrotide? Who should or shouldn't be using Provera? I love Provera. Provera is used in an IVF cycle as what's called the antagonist. And yes, it replaces Cetrotide or Ganirelix, the medication. So what these medications do, they're called antagonists. They prevent you from ovulating. They stop your ovary from releasing the egg. All right. And we want that because you're getting all this stim medication. We're trying to make these follicles grow so that we can get the egg. We don't want your body to release that egg because we want it, right? We don't want it to disappear inside your pelvis. We want to collect that egg so that we can fertilize it. And that's what the antagonist does, the Cetrotide or the Ganirelix. As you know, Cetrotide, Ganirelix, these are injections that you give subcutaneously into your belly, but they can have a downside. These antagonist medications have been around for a long time in the modern age of IVF. They're expensive. It's another shot to give yourself. Sometimes people do break through that antagonist and they can still ovulate. They can ovulate through it. So sometimes it actually doesn't work. And furthermore, sometimes the antagonist can sort of put a squeeze on the ovary and may decrease the number of follicles you get or your follicular growth. Now, Provera doesn't do that. First of all, Provera is dirt cheap. It probably costs $3 for a bottle of 30 of them. So I love that. It's a pill. You take it orally. It should have really nothing in terms of side effects, which is wonderful. So cheap, one less shot, taken orally. It seems to work better, actually, than some of those, than the injectable antagonists. It seems to help to synchronize your follicular growth so that the follicles grow kind of in the same at the same rate. And it doesn't put that same kind of squeeze on the ovary the way the injectable does. So I am using Provera more and more and more in my IVF protocols, and I feel very strongly about it. It's very strongly based in the evidence, and then also just empirically, we see really good results coming from Provera. I think it's great. The only downside to Provera is because it's progesterone. You can't use Provera if you're planning to do a fresh embryo transfer, because that progesterone is what controls the uterine lining. And so if you're using all that progesterone, it's going to mess up the timing. It's going to change things. You can't do a fresh transfer if you're using Provera. I do think it works better than the injectables, and it's cheaper. The injectables are part of the CNY bundle packages, so there's nothing wrong with them. They're still the standard of care, but I'm finding that we're getting really sometimes even better results with Provera with all those other advantages. But if you want to hold out the option of being able to do a fresh transfer, you can't use Provera. So good question there, Kristen, and big fan of you is what I mean. Yes. And the Provera. All right. Let's see what we got over here. What do we got here? All our friends are joining here. So nice to see everybody on the, Shara says hard to hear you. So I hope people can hear me here. If you're having a hard time, please let me know. Yeah, both microphones are on there. So Sarah Burdick says, my husband was just told he has a varicocele. Is surgery the best option? Our CNY consultation is at the end of January. So a varicocele is a set of varicose veins that surround the testicle. And for a variety of reasons, one of which is that, well, it increases the blood flow. Blood carries warmth, it carries temperature. And so one of the thoughts is that it heats up the testicle, so that can have an effect on sperm. It can decrease sperm count. It can decrease sperm function. So when that's one of the things that we look for when we're evaluating male factor infertility. Is there a varicocele, a group of blood vessels that surround the top portion of the testicle? Sometimes you can feel that. So when the guy is having an examination, you can feel it, and they say it feels like a sack of worms, which is kind of gross when you're thinking about where it is, that you really don't want to have a sack of worms there. But nevertheless, that's kind of what it feels like. They're not all palpable. You can't feel them. Sometimes you diagnose them with ultrasound. So the question is that if you fix the varicocele, does it affect the sperm? In about 40% of men who have a surgical varicocele repair, they retain a sperm abnormality. So it's not a perfect solution. Surgery is one option. Another option is to do it through what's called interventional radiology, which is where a specialist type of radiologist can, through a special form of X-ray, identify the blood supply to that varicocele and can basically put a cork in it, which blocks the blood flow, causes it to shrink up. This is a less invasive way to deal with a varicocele. Surgery is typically a little bit more effective, but again, the question becomes, well, is it going to be sufficient to solve the sperm problem? The other thing I would say, Sarah, is, well, it depends on how significant the sperm problem actually is, because if there's a slightly low sperm count that's still going to be sufficient to be able to do IVF, then I would say avoid testicular surgery. Just do the IVF, where it's going to take one single sperm for each egg that you're able to produce. As long as you can get one sperm from that, then you're probably in pretty good shape. There are other things that go into that equation, things about things like the man's age. Has he fathered pregnancies before? So many other situations that can affect it. So hopefully that is helpful. Hi to Kylie. Good afternoon. Nice to see you. Ski and Sand says, for lack of better terms, is CNY able to support a couple with more proactive efforts to become pregnant? I don't want to wait months and months to progress in attempts and options. Well, that is a hard question to answer. Most of the time, once people have their consultation with us, you can move, usually pretty quickly into treatment, whether that's IUI or IVF. IVF is always going to give you the highest odds of pregnancy and the fastest path to pregnancy, but it's also the most invasive. It's the more expensive. And, as anybody who's been through it can tell you, it takes a lot out of you, emotionally. But fastest path and most reliable means of getting there. So when you talk about being more proactive, our goal is to get you pregnant and to get you pregnant as expediently as possible. There are sometimes rate limiting steps there. It is not something that you can kind of make a phone call and be in treatment the next day. There are some things that we have to go through, and it does take a little bit of time with CNY in order to make those wheels turn for you. You have to, things have to be processed through the finance department, through global, or through our nursing team, depending on where you are. But our goal is to get you pregnant and to do so really as quickly as possible. Care 1513, or is that Carrie, is asking about endometriosis suppression med of choice before a frozen embryo transfer, and for how long. So what we know is that with endometriosis, the evidence shows us that if we can suppress that endometriosis for 60 days prior to embryo transfer, we can significantly improve the success with the embryo transfer. My preference is using Myfembree. Myfembree is an oral medication taken once daily. It's very well tolerated. People do very, very well with it. Sometimes insurance covers Myfembree, sometimes it doesn't. Sometimes it'll cover a different medication. There's another medication that's called Orilissa. Orilissa is also an oral medication. It's taken twice daily. And the old standard, which has been around for probably 25, 30 years, is Lupron or Luprolide, Depo Lupron, which can be taken which is given in the form of a shot that's either once a month, or there is a higher dose that lasts for 3 months. Depo Lupron shuts down the entire hormonal system. Orilissa is a more targeted drug that shuts down just sort of the food supply, if you will, the hormonal food supply to endometriosis, while Myfembree is just as targeted, but also gives back a little bit of hormone so that it minimizes the side effects. So those are the 3 options. 60 days worth of treatment is what we recommend. There's also sometimes that we will add some letrozole, which is another oral medication that can be taken with it, because it further helps to decrease estrogen levels. There are some studies that show that that improves. I might consider that with Lupron. I might consider that with Orilissa. I don't do that with Myfembree because A, I don't think it's necessary, and B, it decreases the it makes it so, well, why are you using Myfembree? Because Myfembree is trying to let you still have a little bit of your estrogen, just not the same estrogen that would otherwise be feeding your endometriosis. So thoughts on priming with Omnitrope when you have endometriosis. This comes from Ashton Zuli. There is no contraindication to human growth hormone, which is called Omnitrope, with a history of endometriosis. I have heard some doctors say, oh, no, you can't take Omnitrope if you have endometriosis. You can't take Omnitrope if you have a history of cancer. Endometriosis is not cancer. There is no correlation that I'm aware of between endometriosis and growth hormone. So I would say I think you are just fine there. Hi to BJ Pumping. Nice to see you today. Kelsey is asking, I'm thinking about priming with Omnitrope for my next retrieval. Well, there we go. We're just talking about Omnitrope. I just did a round of egg retrieval without an immune protocol, and I got 3 mature eggs. I have stage 4 endometriosis. Is the Omnitrope juice worth the squeeze? It's expensive. Yeah, it is. So we typically use 6 units of Omnitrope because the data shows that for fertility, using more than that really isn't necessarily helpful. It doesn't, you get diminishing returns. It doesn't do anything more for you. There are some times for a prolonged period, we'll use 3 and then increase it to 6 during your stimulation. I've seen protocols where they use higher doses of Omnitrope, sometimes even 24 units of Omnitrope just during stimulation for very short term. I like to be primed with it, and that's for at least 21 days. 6 units is what you use, and you stay on that for your stim. And I think you're just fine with it. So for the cost of it, I do think it's worthwhile. Growth hormone is what keeps us young. Right? As we mature, as we age, we start to lose our growth hormone. And that's one of the things that contributes to the process that we know as aging. So by getting some growth hormone, we are potentially able to stabilize some of the age-damaged DNA at the level of the ovary. That's why I think Omnitrope is a good idea. Is it necessary for everyone? The answer is no. Certainly folks who have had egg quality issues, that's where we start thinking about Omnitrope. And so I would say, yep, I think it's worth the squeeze. I think it's a good idea in some cases. And I think what you're talking about there is probably worthwhile for you. This comes from Rashmi. Hello, doctor. Hello, Rashmi. I have MTHFR. I'm MTHFR positive for 1 copy of the 2 genes. Can I get pregnant naturally, or is there a treatment for this? Okay, so let's talk about this thing because it's becoming more and more prevalent that people are coming to know that they carry a gene mutation for something that's called MTHFR. which stands for methylene tetrahydrofolate reductase. I just like saying that because it makes me sound incredibly intelligent, and frankly, that's really what's most important. It's about me. Methylene tetrahydrofolate reductase is an enzyme that is involved in folic acid metabolism. And in some people, folic acid um, can be metabolized into a chemical in the body that's known as homocysteine. And homocysteine can be bad for you in higher levels. It can cause things like blood clots. MTHFR used to be something that was very important to us to test for when looking for reasons for recurrent pregnancy loss. Because we know about its relationship with homocysteine, and homocysteine is basically a clotting agent, we would say, well, if you're MTHFR positive, that means you have this gene defect. You're more likely to make blood clots in your body, and if that's the case, then we want to do something about that. What we know now is that MTHFR really has no relationship to pregnancy loss, but it can have something to do with folic acid. So for a while, they suggested that if you have this gene defect, that you take folic acid that's called methylated folate. Methylated folate. Many prenatal vitamins routinely have methylated folate now, so it's not a big deal. And even the current evidence says, well, in fact, you really don't even need methylated folate. Regular old folic acid is fine. So at the end of the day there, Rashmi, yes, you could still get pregnant naturally, even with the 2 gene mutations for MTHFR, because even though we test for that as it's still in the panel for recurrent pregnancy loss, the best evidence shows us that it really doesn't so much relate. So hopefully helpful there. Nurtured Shanna is asking, how does one know that we have an autoimmune issue? Well, sometimes we can test for some of these things, Shanna. One of the most common autoimmune problems that we find is called Hashimoto's thyroiditis, Hashimoto's, or an autoimmune thyroiditis, autoimmune thyroid disease. Basically, your body develops an antibody. It develops an immune response against your own thyroid gland. And I'm pointing to my neck because the thyroid gland lives right here. So if we were going to do an exam and you were going to sit in front of me, I'd put my hands around your neck and I'd feel right here and I would say swallow. And when you swallow, you can see that business move there, right? The cartilage in the neck is moving and I can feel where the thyroid gland is. And once you get used to feel, and if you try it on yourself, do it right now, because maybe you'll feel something. It's hard to feel. You have to feel a lot of thyroids before you start to know kind of what feels normal. Some people have nodules on their thyroid, which is basically where the thyroid works itself up into such a tizzy that it makes a little knot on there. And so we can feel those if you're skilled at feeling them. And sometimes Hashimoto's can have a particular sort of a characteristic feeling when you feel the thyroid gland. But it's easy enough to check for in the blood. And when we're doing your preconception tests, we always check for that. That's called the anti-thyroid antibody, or anti-thyroglobulin antibodies. And that's part of our routine testing. That's probably the most common autoimmune thing that we find. Some people are known to have other autoimmune issues. Sometimes they're peculiar or ill-defined autoimmune things, but sometimes people know they have some sort of autoimmune condition or inflammatory condition, things like inflammatory bowel disease, Crohn's disease, ulcerative colitis, those sorts of things. So how does one know? Well, to some degree we can test. Sometimes we can identify these things in blood tests. And otherwise, we just know that, actually inflammation is the source of all disease. And let me just say that again because it's important. Inflammation is the source of all disease. What is inflammation? Well, inflammation is where your body mounts an immune response against some component of your own body, or that ultimately has some effect against your own body. So let's say that here's an easy one. Let's say you get bronchitis. Ah, no, you know what? Yeah, that is an easy one because you know what it's like to be coughing. Let's say that you get pink eye, right? Everybody knows what pink eye is. Your eye gets all crusty. Well, most of the time, pink eye is a reflection of a viral illness that is most commonly a respiratory illness, but it ends up um, um, causing an inflammation along the lining of the eye that makes all that crusty, business there. It's highly contagious between people, but it's usually viral. Now, we often prescribe antibiotic eye drops because that can help to prevent a secondary infection. It can help to more quickly get you to resolve the pink eye. But believe it or not, pink eye is not actually, in most cases, bacterial. It can be sometimes, but usually isn't. So that's a good example because you look right in the mirror and you see that red, icky looking eye that's all crusty with, junk on it. That's an autoimmune response. That crusty business is your body there trying to mount an immune response against something that it perceives is trying to harm you. All right, so we started talking about bronchitis. Same kind of thing. You get most of the time a viral pathogen that creates some inflammation in the bronchia, in the lungs. And so what happens there is the body says, "Oh, wait a minute, you've got either bacteria or virus, you've got something there that's trying to get me." So what's it going to try to do? It's going to try to build up a response to protect you. And part of that response is that you're going to start making mucus. And that mucus fills the small airways. You start coughing it up, and that's what we know as bronchitis, right? So that's inflammation. It is inherent in really every disease. It's thought to be the initial causes of cancer, and just about every sort of disease process we know. Um, so everybody, and including infertility. So everybody's got some degree of inflammation. Inflammation is what causes heart disease because it's creating an inflammatory process in the lining of the blood vessels that supply the heart. And so what does the body do? It tries to protect you from that inflammation. And so it starts to create plaques. It starts to harden the arteries, if you will, and that's what leads to a heart attack. Right. So, how do we know that we have something that's autoimmune? Well, we all know that we have inflammation, and that's why we typically will offer immune protocols because we know that inflammation is in everybody and definitely has something to do with infertility. So, there may be some specifics that we can't name in each individual, but um, we know that we can probably help some cohort of the population and certainly not hurt them by providing these anti-inflammatory or autoimmune type protocols. So good question there. Let's see what we got going on here. Timeless Aries. I'm 44 with extremely low AMH. I will have an ovarian PRP done in a week. How long should I wait to have an IVF cycle after the PRP? So ovarian PRP, as you may know, is where we take your tissue, a tube of your blood, and shake it down in such a way as to take out your body's healing components, your tissue factors, your growth factors, and we can do different things with that material. And in this case, place it back in the ovary, which can improve blood supply. It may help the ovary, to kind of be younger. That ovarian PRP, or what some people call ovarian rejuvenation, is something that I really like. I have seen really great outcomes from it. So if you suffer with a low ovarian reserve or poor egg quality, it may be something to consider, but it's experimental. There's not a lot of evidence behind it yet that can show us specifically what protocols do we want to use, how often, how much, when to do it with regard to timing. So, usually, what I recommend for folks there, Aries, is about 4 weeks that you would do it maybe at the beginning of your cycle, and then in the next menstrual cycle, you could start a stimulation. What some people do is that they will do an ovarian PRP. With the next cycle, they will start to do their IVF, they will do their stimulation. And at the same time, do another PRP, which then helps them for the following cycle. So then you're getting kind of the double benefit of a couple of doses of ovarian PRP and doing a back to back cycle. Because when you stack your cycles like that, in theory, each successive cycle should give you progressively better and better outcomes. So, good question. Thanks for asking and thanks for being here. Gosh, we've got about, looks like maybe about 10 more minutes here or so to try to get your questions in. And I'm going to go over to Facebook next because I haven't been ignoring you. We got Facebook and LinkedIn right here in the middle, as well as YouTube and two different Instagram feeds, Randy Fink MD and the CNY Fertility feed. If you don't follow me on Randy Fink MD, please do so. We try to put out enough useful and entertaining material to keep you occupied and maybe learn something while you're at it. KG says, I had a MC in June and an ectopic a miscarriage in June and an ectopic in October. My HCG is finally negative as of today. I'm retesting the next few months. So nervous to try again. Well, after you've been through a couple of things like that, no wonder you're nervous. I got to tell you something. If you've ever been here with me for an egg retrieval, I'll come in, we'll meet, and a lot of times I'll say, how are you? How you feeling? And a lot of people say, frankly, I'm nervous. And I would say, is it any wonder that you're nervous? Of course you're nervous. You don't do this every day, but fortunately we do. So that makes it, kind of all the better and all the easier. Most people don't have an operating room with an ultrasound and anesthesia set up in their living rooms. Some people do, and I applaud you. We don't judge here. So of course you're nervous. And just like HE, of course you're going to be anxious about this because you've had some bad experiences. Now, pregnancy hasn't been a happy thing for you between a miscarriage and then an ectopic pregnancy. You still are expecting to think about this process as though it would be all full of happiness. Pregnancy is going to be very frightening for you until you have your baby. And once you have your baby, things will change. I would feel very confident, not knowing anything about you, but just the vibe. I feel confident that there will be happier times ahead. And once we experience these happier times, the trauma that we've had to go through to get there really often becomes very minimized. And the best example of that is, having been an obstetrician in general practice and having delivered probably close to 10,000 babies, which is an amazing experience. I have to tell you, and every one of them is different, despite whatever is the same, every one of them is different. Every one of them is special. Every one of them, honestly. It's a wonder that we as a species would continue, that a woman would want to get pregnant more than once, because the process of labor and delivery is it's beautiful in some ways, but it is also it can be difficult. It can be challenging, and even the most normal, safest, happiest, easy delivery is still associated with a lot of pain. It's associated with blood, and it's associated with fear, and it's associated with all kinds of things. And you know how quickly the human brain forgets about that, because you would think that that would be the best kind of birth control there is, having had to go through labor, having had to have a delivery, and then amazingly enough you're willing to do it again, because there's something about that love for parent to child, something about holding that baby in your arms that makes you say, you know what, however bad it was, it wasn't that bad. So happier times ahead there, Keiichi, sincerely. Okay, Olga is asking about explain day 3 or 5 embryo transfer. What's the difference? Well, so depending on how many embryos you have, we generally make a recommendation that, well, okay, if you have 5 or more embryos, we suggest, well, grow that embryo to the blastocyst stage, which is typically going to be a day 5 embryo. Because when they grow to day 5, they grow into a little functioning machine. A day 3 embryo is what's called a cleavage stage embryo. It's still struggling to try to grow, to try to figure itself out, to try to know if it's even going to be able to survive. There's nothing wrong with a day 3 embryo. So if you're limited in the number of embryos that you have, if you have 4 or fewer, our general protocol is to recommend that you either freeze or transfer on day 3, because we would much rather see that embryo going inside of you than an embryo potentially not growing in the lab. There are some practices that will require you to grow those embryos to blast. We do not do that. We want that embryo to be in you, because there it may have a chance that it doesn't have if it's just growing in the lab. So, depending on the number that you have, a blastocyst or day 5 embryo is more likely to get you a baby because it has survived longer. It has grown from the point of being a cleavage stage embryo to a little functioning living machine that is churning itself onward, right? Whereas a day 3 embryo is still just dividing. We don't know what's going to happen with that day 3 embryo, but at least the day 5 embryo, we know it has made it to the point where it has reached a milestone, and that milestone we call being a blastocyst. So really it depends on how many embryos you have. So hopefully that when there are no other issues present in the semen analysis, such as motility or volume or sperm count. Sperm morphology is the way the sperm look under the microscope. Now, what does that mean? It means that somebody is trained to sit and look under a microscope and to be a judge of what they think your sperm looks like. Sperm have heads, they have necks, they have tails, they have all these different little tiny anatomic features. And so what we know is that 97% of sperm can be abnormal. 97%, 94%, 96%, sorry, of sperm can be abnormal, and still that's considered to be normal. In what's called strict morphology, a 4% normal forms is considered normal. So isn't that crazy? 96% of them can look abnormal, and that's still normal, because it only takes how many sperm to fertilize an egg? Bing, just one, only one sperm. So morphology is said to be not something that is a cause of infertility, but is associated with couples having subfertility. Couples having fertility issues are more likely to show morphology issues. But they may not be reproducible. So 2 different technicians looking under the microscope may give you a slightly different number. So if a couple is having a difficult time getting pregnant and the morphology is low, we may suggest something like at least doing an intrauterine insemination or an IUI, so that we can kind of try to help separate out the best and the strongest swimmers. There's another device that's called Zymot, Z-Y-M-O-T. I think some people pronounce it Zymote. And particularly for those with morphology issues or with unexplained infertility, I usually recommend that you allow our lab to use the Zymot device, which is an add-on in the lab. It's a $200 add-on that in theory separates out the best and the strongest swimmers in the group and makes for better outcomes. So hopefully that's helpful to you there, Darian. Sorry I didn't get to Crystal and Christy and Mandy here. Well, Mandy's asking, talk about thyroid levels. Preconception labs are 3.2, but I'm reading, yep, we want thyroid to be between 0.5 and 2.5. And if it's not, then usually we will place you on a low dose of thyroid medication. By the same token, even if your thyroid is normal, but you have those anti-thyroid antibodies that we just talked about causing Hashimoto's thyroiditis, then we often will treat that. Most practices will treat it. We are going to run out of time here tonight. Gosh, we had so many good questions from such good friends here. And thanks so much to everybody for being with me tonight. It's top of the hour now, 7 o'clock on the East Coast, which means we are done with Fertility with Fink and Friends for another week. And I hope you'll join me next Tuesday, as always. As I am fond of saying, a couple of things: choose kindness, choose love, and choose hope. Fertility is not the book of your life. It ain't your novel. It is merely a chapter. And what we're here to do is to help you rewrite that chapter. So from Colorado Springs, let me say thanks so much for being here. Good night.